Right, here's the heart failure lecture. There's the objectives. There's a video that I have on Blackboard as well about the blood flow if you would like to watch it. A recap of what heart failure is. It occurs when the heart is not able to perform its task of pumping blood efficiently, and this results in the body's inability to meet demands for oxygen and nutrients. When a person has heart failure, it indicates that they have some kind of heart disease, where there's a problem with the contraction of the heart, which is systolic dysfunction, and filling of the heart, which is diastolic dysfunction. Some facts about heart failure, nothing that I'm going to test you on. I just want you guys to know how pervasive heart failure is. So please, if you want to know some facts, there they are. This is a map from the CDC that talks about heart failure deaths across the country. And we're pretty red here in South Carolina, not as red as maybe Mississippi is, but pretty red, so we should know heart failure. So we have systolic and diastolic heart failure. Systolic is a weakness of the heart muscle, and diastolic means that they're stiff and they're non-compliant. The ejection fraction, which is how much blood is ejected with each contraction of the heart, will help determine the type of heart failure. A normal EF is 55 to 65. That's determined through an echo. And it's normal in diastolic and reduced in systolic. So it's reduced in systolic because the heart muscle is weak, whereas in diastolic, the heart muscle is stiff and non-compliant. This is the level of activity that makes a client symptomatic, is how you stage it. One of the ways you stage it, then you also stage it based on their natriuretic, like I said in class. You don't really have to know the stages for me. It's just there so you can have it if you would like to read it. This is a heart failure video by Khan Academy. I think I have it up on Blackboard as well. But if you should have any questions, if I didn't explain something clearly, please watch this video and it should help clear it up for you. And if you, after you watch the video of that and you watch my video and you have questions, please feel free to ask. So preload and afterload. Preload, remember, is the volume that is entering the ventricles, and afterload is the resistance that must be overcome in the left ventricle to circulate blood. When we promote health and prevent disease, we're going to promote exercise, of course, a low-sodium, heart-healthy diet. We're going to restrict our fluids if they have heart failure, smoking cessation, medicine adherence for heart failure, and then if they have heart failure, they need to routinely see their primary care provider. This video is another video from Khan Academy about compensation and decompensation, which I didn't really talk about in class. You don't have to know this video to do well on the test. However, some people might feel that they would understand things better if they were able to understand compensation and decompensation. So basically, we compensate by increasing our stroke volume, increasing our heart rate so that our cardiac output is increased. Because remember, cardiac output is stroke volume times heart rate. So we do those things by also increasing our preload, increasing our heart rate, increasing our stroke volume, and also with bulking up so that left ventricular muscle can get big. So we increase our preload, that increases filling, which helps us contract more, increases our stroke volume, which increases our cardiac output. We increase our heart rate. We have to make our heart rate beat faster, which will increase our cardiac output. And then our body lastly compensates by bulking up our cardiac muscle, and that also helps our cardiac output. And then our body, of course, can't keep up with these things, and we start to decompensate, and we're not able to feel as well. We're not able to increase our heart rate as well, and our cardiac muscles start dying off if we bulked up. The video explains it very well, I think, so if you have questions about compensation, decompensation, and you want to watch the video, please feel free, but you don't have to watch the video to do well on the test. All right, remember the heart failure causes. We use the acronym FAILURE. F stands for fatty heart valves. A is arrhythmias. I, infarction. L, lineage. U, uncontrolled hypertension. R, recreational drugs. And E for evaders. So, remember, any type of ventricular atrial arrhythmias can lead to heart failure. MI can lead to heart failure. That's your infarction. Uncontrolled hypertension can lead to heart failure because remember, if hypertension is uncontrolled, you can have target end organ damage, which affects the brain, the heart, the kidneys, the vasculature, and the eyes. 2 for 1 in there. These are our major and minor risk factors per Honan. Major risk factors that you really need to know about: high blood pressure, valvular heart disease, and obesity. The ventricular, the left ventricle gets big from hypertension. That can cause heart failure. Being over age 65 can be a significant risk factor for heart failure because the older you are, the more times your heart has been beating, and unfortunately you start to develop symptoms of all sorts of things and heart attack. And then you have your minor issues such as sedentary lifestyle, diabetes, drinking too much, smoking. So what is right-sided heart failure? So right-sided heart failure is when you start to have congestion that is backing up into the tissues and organs from the right ventricle of the heart not working. So failure of the right ventricle causes the heart to stop accommodating for venous blood return. You start getting JVD because of this increased venous pressure. And this increased venous pressure also causes an increase in hydrostatic pressure. And what that means is that you basically have excessive fluid circulating in your body. With left-sided heart failure, you have pulmonary congestion because your left ventricle is not working appropriately. The left ventricle is not able to pump blood into the systemic circulation, and the pulmonary pressure, pulmonary venous blood volume is increasing, and this causes the capillaries to force fluid into tissues and alveoli, and thus causes the pulmonary interstitial edema and the impaired gas exchange. So left-sided, pulmonary, right-sided, body. Now, this doesn't mean that you can't have right and left-sided, but if you see right-sided heart failure, you need to think of body, and if you see left-sided heart failure, you need to think of lungs. So your symptoms for right-sided, you're going to have JVD. You're going to have dependent edema, and it's going to work its way up, just depending on how bad the heart failure is. Starts at the feet, moves up, legs, ankles, sacrum, scrotum. So if you have a patient that is in the bed and they can't move around and they have heart failure, the edema is going to be dependent. So if they're laying on their back, they're going to have edema in their sacral area, have edema in their legs. If they're laying on their, so if they have edema in their scrotum, what you want to do is elevate their scrotum. They can have abdominal distension and ascites, fatigue and weakness, nocturnal polyuria, which means that they're peeing at night, enlarged organs, and weight gain. That's right-sided. Left-sided, remember, is backing into the lungs, so they're going to have shortness of breath, orthopnea, which means that they're going to be short of breath laying flat, which I forgot to talk about in class. and nocturnal dyspnea, which is shortness of breath at night. A lot of these patients will end up sleeping in recliners because they can't breathe laying flat. Again, you're going to have an S3, going to have pulmonary congestion. You will have patients who are having organ failure, and because they're having organ failure, they're having a decreased perfusion to their organs. Their kidneys are not perfusing like they should be. The body is going to want to hold on to their urine, so they're going to have oliguria. The sputum is going to be frothy and blood tinged, which could be a sign of significant acute heart failure. Your lab test, you're going to have your natriuretic, and like I said, it's a marker of heart failure, basically. So the more, the higher it is, the worse your heart failure is. Other diagnostic tests, the echocardiogram, which will look at your EF to see how well your heart is functioning. You have the chest x-ray and the EKG. The chest x-ray is just to look and see if you have any pulmonary congestion. If you're having any arrhythmias, you'll have an EKG. Certain labs will be done. So if they're having, if the doctor's concerned that there is ischemia, they're going to do troponins. Going to look at your electrolytes to make sure that electrolytes are okay, because remember, if they're off, they're going to be significant. They can significantly affect the heart. And then ABGs. So make sure that we're perfusing okay. Our nursing care, we're going to make sure we weigh these patients daily. Same time, same clothes, same scale. Monitor their I's and O's. Remember that we're going to position them first to maximize ventilation. And if they're not adequately oxygenating with the positioning, then we will administer oxygen as prescribed. Want to look at our vital signs, monitor our ABGs, of course, our oxygen level, our chest x-ray, our electrolytes. Keep assessing for signs of medicine toxicity. If they are having an acute exacerbation of heart failure, we're going to encourage bed rest until they're stable. We want to cluster our care and encourage energy conservation. Maintain dietary restrictions. So for a heart failure patient, that would be low sodium diet, restrict their fluids if needed, heart healthy diet, and then provide emotional support as needed, because some patients might not know how to deal with heart failure. When you're admitting a patient and you're looking at your medicine list, you need to ensure that they also include herbal supplements, because some herbals can cause issue with the cardiovascular system. And they need to be educated on this if that's the case. Like St. John's wort, it complicates a lot of things. Sorry, that's just going to sound weird. So St. John's wort can cause a lot of issues with depression, with the heart, with renal. So you need a full list of all medicines that the patient is on, not just prescription medicines. So diuretics, they're going to decrease our preload. Remember, preload is the volume filling into the right ventricle. We have a loop, thiazide, and potassium sparing. Some considerations to think about is IV Lasix. You need to give slow IV push, not faster than 20 milligrams a minute. The reason is it causes ototoxicity when we have too rapid of an administration. Other things that we want to remember is that loops and thiazides can cause hypokalemia, whereas potassium sparing can cause hyperkalemia, and they may require supplementation if they are on loop or thiazides. Client education is you want to give high potassium foods. You want to educate them on high potassium foods for loop and thiazides, and you might want to educate them on what foods to stay away from if they're on a potassium sparing. And of course, orthostatic hypotension, especially with our elderly population, every blood pressure medicine, that would be true. Our afterload reducing agents, So the afterload, remember, is the amount of resistance that the blood has to overcome the left ventricle. So basically, this is going to be like medicines that reduce blood pressure. So your ACE1s, your ARBs, CCBs, and phosphodiesterase inhibitors. Your considerations is it's contraindicated in those with renal deficiency. However, ACE1s do protect the kidneys for those that are diabetic. Monitor for hypotension after initial dose, especially with your ACE1s. Angioedema is a very important adverse risk factor for ACE1s and ARBs. And monitor for increased level of potassium with your ACE1 and ARBs. Client education, you want to inform the client that you can develop a dry cough and that they should notify the provider if this were happen. And they need to notify the provider of swelling in their face or extremities. They need to know what angioedema is, and they need to be able to seek emergent treatment. And then, of course, monitor for orthostatic hypotension. That's true for every one of these. So in the next few slides, I talk about inotrope and chronotrope because Honan does. So I will not be saying inotrope or chronotrope on the test. However, you need to understand what these terms are if you were to come across them, say, on the NCLEX or out and about in the nursing world. So inotropes will increase or decrease the contraction of the heart, and chronotropes increase or decrease the heart rate. So digoxin will help to increase the contractility and improve the cardiac output. Digoxin can increase the heart rate, so it's a positive chronotrope, and it will increase contractility, so it's a positive inotrope. Dopamine and dobutamine are more for critical, so it's not really something that I want you to know about, but they are inotropic agents. So for digoxin, you're going to monitor the apical pulse for 60 seconds, observe for nausea, vomiting. Remember, well, you don't have to remember, but dopamine, dobutamine, and milorone are given IV, so they're only going to be given in a critical care unit. Client education is to make sure the client understands that they should check their pulse for 50 seconds prior to administering. If outside the parameters or if it's irregular, they need to hold and notify the primary care provider. Digoxin toxicity does not cause bradycardia. It causes the pulse to be rapid and irregular, just so you know. You want them to take it at the same time each day, not to double dose. Don't take it in the same time period as antacids, because antacids will decrease the absorption. Report signs of toxicity. What are signs of toxicity? Visual halo, fatigue, weakness, nausea, vomiting, anorexia. And then you need to have your potassium levels checked regularly. Remember, hypokalemia can potentiate dig toxicity. So beta blockers are considered negative inotropes and negative chronotropes because they help to lessen the contractility and decrease the heart rate. So they do this by blocking the catecholamines, which increase the heart rate and cause peripheral vasoconstriction. Your big nursing considerations are to monitor your pulse before you administer, because if your pulse is lower than 60, you don't want to give it. And you also want to look at the blood pressure before you give it. This medicine can cause somebody to have activity intolerance, to be sleepy, and to be orthopnic. And again, orthostatic blood pressure. Client education, you want to teach them to weigh daily. So if they have heart failure, you should be teaching them to weigh daily regardless. And to take their heart rate and monitor their blood pressure immediately before taking. So the only medicine that's given IV for acute heart failure is this Neseritide. It's a B-type natriuretic peptide, and it causes diuresis. And that's all I'm going to say about that. Some vasodilators, nitroglycerin, isosorbide mononitrate. I don't really see vasodilators in heart failure very much, but your book did talk about it. So vasodilators can relax the smooth vessels of the heart, and they prevent coronary artery vasospasms, reducing the preload and afterload, and decreasing the demand of the oxygen demand of the heart, excuse me. Again, nursing considerations, orthostatic hypotension, and generally treat angina. Client education, well, I went into a long spiel about client education and nitroglycerin, so if you need to refer to that, please do. Remember that a headache can occur with nitroglycerin, and you would suggest that the patient take like a Tylenol or something for such a thing. You want to encourage them to rise, sit low, lie down slowly, because again, they can get orthostatic hypotension. So important education. Very, very important to teach your patient to weigh themselves at the same time every day with the same type of clothing on the same scale. That's very important. If they have a weight change of 2 to 3 pounds per day or 5 pounds in a week, they need to let their primary care doctor know or adjust their diuretic. Some interprofessional care, you're going to have cardiac on board, probably pulmonary on board, especially if there's left-sided heart failure going on. You're going to have like respiratory therapy, heart rehab, and nutrition on board. So pulmonary edema, which is a significant complication of the acute exacerbation of heart failure, this is cardiogenic because there is a pulmonary edema that is non-cardiogenic. It's an abnormal accumulation of fluid in the lungs, causes anxiety, tachycardia, shortness of breath at rest, level of consciousness changes. You're going to see a productive cough with frothy, bloody tinged sputum. Your actions are to treat this as an emergency, because that's what it is. Raise the head of the bed. That's the first thing you're going to do. Raise the head of the bed. Provide oxygen as ordered. So if you raise the head of the bed and they still are in distress, you need to do a little bit more. So give them oxygen. You can do BiPAP or mechanical ventilation. A lot of doctors are doing BiPAP because it's not as invasive as intubating somebody, but sometimes BiPAP doesn't work and you have to. Then they're going to give them IV pain medicine to help with the anxiety, and then loop diuretics, which will help with fluid accumulation. And then cardiac arrest. So as soon as you recognize that a person needs CPR, you need to get help. The only exceptions are near drowning, overdoses, or respiratory arrest. So in those cases, you would do CPR first for 2 minutes and then get help. You need to recognize what to do. So now this mnemonic is CAB, and if you have an AED, you would defibrillate as well. So circulation, airway, breathing, and defibrillation. And remember that sweet little video I showed you with Z-Dog. It's right here. All right, so those are my references. This has been the heart failure overview. I hope you have enjoyed it. I hope it helps. And if it doesn't, I'm sorry. And if you have questions, please don't forget to post them on the discussion board.